Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
All right. So everyone's just starting to study, right? We're all just starting that.
Yeah.
Well,
for the most part.
Yeah, that's good. 3 months is an appropriate amount of time. There's 12 sections. If you guys haven't looked over the blueprint, it's a good thing to do because the actual exam runs in that format. You go up on the day of, you're in this like big center, and once you go to your exam room, you stay there for the entire 4 hours. You're allowed bathroom breaks and all that, but the examiners, 2 of them will switch out for each of the 3 sections. And there's 3 sections comprised of 4 cases each. These cases sort of blend into each other a little bit, but they do keep them at 12-minute intervals. So you want to try to get all the points you can in those 12 minutes. There's not time for thinking. There's no time for just kind of sitting around waffling on what diabetes is or something like that. All those things should just flow out so you can actually get to the deeper part of the case within that 12-minute time. So let's jump into the first one and we can keep answering questions as we go. I'm going to share my screen here.
So those 48 minutes straight, Ryan, those 4 cases are back to back per section and examiner group.
Yeah.
Like take a couple of minutes in between, they just keep rolling.
Yeah. And it flies, man. You kind of don't realize you're sitting there hopefully in the zone and not freaking out. Let's see. I'm going to share my screen here. I got the first case up. That's top 2. All right, so let's kick this off. Okay, you have a 35-year-old male who shows up at your office complaining about pain associated with the lower left molar. And just a little aside here, Mo, I might interrupt you. It's just how the exam goes.
All right, cool.
So what do you want to know next?
So I'd want to know how long this has been going on for. Did he get referred to me or did he show up on his own? Does he have any constitutional symptoms? The rest of the HPI associated with it, medical history.
Understood. So he has, he says he has diabetes, hasn't really assessed it recently. This has been going on 3 days. He can't really chew. He feels like it's a little swollen, but he doesn't feel as if he's running a fever or anything. What would you like to do next?
Start with a physical exam.
Can you describe your physical exam?
So I would first assess just generally how the patient looks. Does he look like he's in any distress? Then I would start with an extraoral exam, looking for any erythema or swelling or asymmetry of the face. I would palpate extraorally. I would check to see if I can feel the inferior border of the mandible and if there's any fluctuance extraorally. I would assess for trismus. I'd see his MIO. After that, I would move intraorally and do a general exam. Intraoral, check how the tissue looks, see if there's any swelling, erythema, purulent drainage, fluctuance.
Good. So on your intraoral exam, you kind of find this. He says he's in some pain when you kind of palpate the vestibule there. What would your plan be at this time, assuming this is just limited to this tooth? Your assistants say the imaging is broken. You don't have a scan. Not today.
Okay, so if I don't have a scan, do I have a PAN? Do I have a PA? Do I have any ability to take any type of imaging?
Yeah, you have a PA from the referring dentist that shows the crown with a little inflammation around it.
Okay, so based off this, he does have an active infection, so we do need to manage it. It looks like there's some swelling in the buccal vestibule there with some overlying erythema. And the positive aspect of this is that there is spontaneous drainage on its own, so it's not collecting too large.
So what would your plan be for this patient?
You definitely need an incision and drainage, and I would consider taking the tooth out if it was non-restorable, but I would want to talk to his dentist that he got the PA from and assess if the tooth is restorable or not. And well, you did mention he's diabetic, so we need to also make sure that his glycemic control is good.
Yeah, so we're going to ignore the diabetes part for now, but assuming that's under good control and the dentist says the tooth is non-restorable, what would your final plan be?
So I would take out the tooth and do an IND.
Okay. Would you do it under sedation or not?
Did you say any trismus?
No trismus. You can get him open.
Yeah, I would do it under sedation.
Okay. So you take out the tooth, everything goes fine. You get maybe a cc of purulent drainage. Thankfully, you gave the patient your cell phone number and you're out at a swim lesson with your kid the next day, and actually in 3 days. And he texts you a picture. It looks like this. He says, "Doc, it really hurts. This kind of blew up overnight." What do you think's going on?
So I think he has recurrent spread of the infection, and that's tracking down to the inferior border of the mandible and down to the submental, submandibular, and sublingual spaces, with extension out to the buccal and to the.
Yeah. What would you do at this time?
I would tell him he needs to go to the emergency room and receive a CT with IV contrast to further assess the situation and to evaluate, monitor, and manage his potential airway compromise.
Would you meet him in the ED?
Yes.
So he gets a CT scan in the ED. Are there any contraindications between any diabetes medication and IV contrast?
So with IV contrast, typically the diabetic medications with metformin, you need to be careful. Also, they may have some renal compromise, so I'd need to check out his renal function on a BMP, check out what his creatinine and BUN is. And,
I understand. So all that returns just fine. Kidney function is normal. This is what the scan shows. Can you describe what you see, if anything?
So I see two things that stand out right away. The first thing that is abundantly clear is that the airway is deviated to the right side, and there's some mass effect from a rim-enhancing collection of the left mandible that seems to be wrapping around the inferior border from the buccal down to the submandibular space there.
Right. So what would you want to do at this time?
So I would want to tee up this patient to go to the operating room.
Sure. What does that involve? Are you what does your plan look like? The attending physician in the ED wants to know.
So I'll tell the attending physician to make this patient NPO, to contact anesthesia to get the patient ready to go to the operating room. I would also want the patient to be seated up. I would inform them not to lay the patient back. I would keep a Yankauer suction bedside, and I would start empiric antibiotics. I would have them on 3 grams of Unison every 6 hours. I would also
the attending doctor says he hasn't gotten a set of vitals or any labs. Are there any you want?
Oh yeah. So I would want all the vitals, regular vitals, temp, BP. I'd also want to assess the CBC as BMP, and since we're going to the operating room, I'd want the coags and type of screen.
So he does have a white count of 19. He's febrile at 38.7. Besides that, everything else is fairly unremarkable. Blood pressure is a little high. The attending physician also wants to know if there's anything you want to tell anesthesia beforehand.
So I'd want to tell anesthesia that there's a high risk of airway compromise in this patient, and that we should likely do an awake fiber optic intubation while having everything for a surgical airway ready in the room in case.
Sure. So you're in the operating room. Everything's prepped and draped. Can you describe your first few steps in this procedure?
So a patient's prepped and draped, intubated. I would mark out the inferior border, try to palpate it best that I can, and make an incision about 2 centimeters below the inferior border with 15 blade. Then I would continue blunt dissection up to the inferior border of the mandible. On this patient, I would need to blunt dissect both of the buccal and lingual aspects of the inferior border to attempt to drain as much purulence as I can, going to identify any additional loculations in the area. After blunt dissection, I would copiously irrigate the area. I would put some drains in there. I would also then go intraorally and assess if there's any additional collections or palpation of fluctuant masses, and I would open them up as well.
I understand. So where would your drains be?
I would put a drain on the lingual and on the buccal of the mandible. I would put 2 drains, and I would consider.
So you actually place those drains. What is your post-operative plan for this patient include?
So post-operatively, immediately after leaving the OR, I would want the patient to go to the ICU and remain intubated overnight, at least for the first night. And I would keep the patient on IV antibiotics, make sure the patient is getting adequate fluids, close glucose monitoring, and likely an insulin sliding scale for this patient. I would monitor.
At what point would you consider? Do you round on this patient?
Yes, I would round on this patient very frequently, and
about every 12 hours you're going in and checking on this patient despite your busy clinic schedule. What criteria do you use to determine whether this patient is ready for extubation?
One of the main ones would be a leak test and the edema that's around the tube itself. I would also want to make sure that the patient is afebrile, that the vitals are stable, and he's able to maintain good oxygenation.
So the white count is trending down. You determine that there's a good cuff leak test. You extubate this patient and send him home. A couple days later, though, he says he still has swelling, and he texts you another picture that he looks like this. What would your concern be at this time?
It appears that he's got swelling of the bilateral neck, and that the erythema is tracking to the opposite side as well. So I'd be concerned about possible progression to Ludwig, incomplete resolution of the infection, and as the erythema is tracking down to the chest, it appears I would be concerned for possible descending mediastinitis as well.
Yeah, on your physical exam, you sort of get this feeling of popcorn or a little bit of crepitus almost. What does that kind of make you think of?
So the crepitus is likely anaerobic bacteria producing gas, which would make me think that there may be progression to neck fash.
Mm-hmm. So your next patient is a consult from your neighborhood pediatric dentist. He's a 7-year-old male. He had a tooth number H filled a few days ago. He looks like this. You decide to meet him in the emergency department. He's in the emergency department right now. Everyone's looking at you saying, what should we do?
So I would tell them that the first thing we're going to do is we're going to prepare this patient for admission right away, because kids could decompensate pretty quickly. So we need to have this kid admitted and monitored and placed on.
Yeah. So the kid's febrile. He's got a white count. Values. That's all the ED physician tells you. There's no specific values to that. What would you like to get next in terms of information?
So we have the vital. I want to know if he's got any past medical history or any.
No past medical history or anything. The ED physician shows you a scan. Specifically this cut, the radiologist put an arrow to that. Can you describe what you see there?
So in this cut, again, I see a CT scan. This is an axial cut, soft tissue window showing a rim enhancing collection of the appears to be in the right orbital.
They flip the image around.
Okay,
ED physician says not to worry about that.
Okay, so it's on the patient's left there, and it looks like it's in the orbital region, causing possible displacement of the left globe.
Yeah. What would your plan for the patient be at this time?
So I would consider, I would need to do
let's say you're in the, sorry about that. Let's say you're in the operating room. Everything's prepped and draped. You're getting ready to do an I&D of this patient. You've determined it's a canine space. You've determined that there's a collection in the orbital cone. Would you place a drain in the orbital cone?
Yes.
Sure. That's the end of the case.
All right.
That was a full 13 minutes almost, Mo.
Nice.
That was really good. I like that one. And applause for being like the first one to go on that.
Thank
I know
you.
that's not easy either, and it takes some balls. So let's go back and review a little bit. I thought you did a great job overall. First of all, how'd you feel?
Felt pretty good. It's I'm trying to think about what you're thinking of.
Yeah.
So I'm trying to be like a step ahead of you.
That's why these cases are signing up to be an examiner and an examinee are both equally beneficial, because you learn what it's like to be in both seats. Like as an examiner, you're trying to egg the person in the hot seat on. And as an examinee, after making a couple cases and walking people through it, you kind of know what they're getting at, hopefully. And that's why this exercise is so important. You can read all you want for this exam. You can, study old notes and stuff, but practicing on both sides, it's the most important thing, man. So you did well. We had a 35-year-old guy, lower left molar. You did all the right things. Passed all these first things. I'm glad we're starting off with an infection case, because all these first things that should be automatic, you should practice them. They should roll off your tongue, exactly like what are in the sound bites. You should know when you get a patient like this, past medical, surgical, social history, allergies, any medications they're on. You should be able to rattle off your physical exam for an infection specifically. Your physical exam when you're in the TMJ section will look different. Your physical exam when you're in the trauma section is going to look different. But you did it exactly.
Hey yo. I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege, I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you cake or so.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.